Definitely harnessing regional support. That South to South collaboration, that India, South Africa, because the whole rationale behind that Africa India blueprint or that report that we just published is a learning from similar countries. So
Yes.
definitely an inward look. An inward look, not to say we don't need anyone from outside, but an inward look in terms of what do we have, where are we going, where are our wins, and where
Yeah.
and what do we have as a region. Definitely an inward look and an inward look, but also an inward definition of what we define as health security and
Yes.
health sovereignty in terms of us. We need to not feel like we are being pulled by a master, and there's a degree of that is still happening. So health being a priority, but us feeling that we have got our health under control. Health doesn't yet see mental health as a big issue. That is also more of an African thing. I think in other countries, maybe because psychology and psychiatry and all these things are big. But I've read a couple of policies of mental health in from African countries, mostly South Africa. Health, mental health is still and it goes back to my earlier point of saying that a lot of health issues are still framed in a medical way. So mental health is still, they'll start talking about how mental health has grown because we all know that there's a rise in mental health issues. We've seen a rise in suicide and
Yes.
suicidal thoughts, especially in young people. AIDS. There was a lot of things that you couldn't say because of a clause in
Source of
something that
funding.
you have signed,
Yeah.
and because there's even a clause that you would sign. For example,
Yes.
this one funder, whose name I will not mention.
Of
For
course.
example, they do not believe in termination of pregnancy. But the National Department of Health has got a big chunk of work in terms of giving young people that as part of the sexual and reproductive health and rights package. But you cannot work freely in that. And it's not about whether you as a person believe in it or not.
If you value cutting edge research and want to hear more academics share their work, subscribe, hit a like, leave a comment, and help us grow this community. Your support makes it possible for more PhD scholars to share their insights with you. In this episode, we examine structural weaknesses exposed in African health systems after COVID-19 and the political choices shaping reform. My guest unpacks mental health prioritization, data governance, and the future of universal health coverage on the continent. The conversation moves from national policy to global health diplomacy, asking what durable health sovereignty should look like for Africa. Dr. Njabulo Banda is a public health researcher and deputy dean for research at the Independent Institute of Education, EMIRIS. Her work focuses on strengthening health systems, mental and youth well-being, and information governance in African context. She also contributes to continental policy debates on health system strengthening and equitable health for all in the context of SDG 3, which are the Sustainable Development Goals number 3. The Solomon Atah Podcast starts now with Dr. Njabulo Banda. Doctor, good morning. Welcome.
Good morning, Solomon. Thank you so much for having me. And thank you for being so kind as to, just find my work that interesting that we should have such a session. Thank you so much.
No, you are working in health strengthening sustainable goals number 3, sustainable development goal number 3. That's very important, health. So what is the overarching area that your PhD was focused on?
My PhD was actually focused on health literacy and health information. And I really myself struggled right throughout with it. Not struggled in a bad way, but struggled because it's such a complex area and it's so important, yet it's so fundamental for health. So my topic, if I can just say it out, it was a bit lengthy. It was the effects of visual aids on HIV health information in persons with low literacy. So I explored using visual aids as an alternative way to communicate health information to people who are not necessarily illiterate, but who have low literacy. And the whole background was that a lot of people utilize the health systems, a lot of people go there. But remember, health is not just about you discovering that you have a cough today and going there. It's also about knowing how to manage yourself. And this is something that maybe, as I suppose, countries of the West they talk a lot more about self-management and all those things. And also because of maybe different education levels, so people are able to access and utilize health information. So my main inspiration for the PhD was that I'd worked a lot in public health,
Yeah.
having worked in the NGO sector,
Mm.
seen the clinics, the state, and the work. And I really felt that the government is doing so much. There is free ARVs, there is nurses. We used to train nurses every now and then, sorry, in terms of updates in how
Yes.
they manage, But I felt that this is just not enough. People
Mm.
are not taking their medication. They are not taking care of themselves. There's a
Mm.
lot of people that are missed. They call them lost to follow up
Mm.
in the HIV program. So
Mm.
that's why I was pained by this. I wanted to know why is the amount of efforts going into the program not equated to the outcomes that we are seeing
Mm.
and the positive results. And I
Interesting.
found that, yes, one of the ways I then boiled it down to, I started off with the topic saying that the issue is adherence. And you could tell that I'm coming from the public health setup because,
Mm.
they love throwing these big terms around. But thank
Like, yeah.
big terms like adherence,
Mm.
which is a great thing. But
Mm.
what is adherence?
Yeah.
So when working with my supervisor, and I think it helped that neither
Mm.
myself or her are actually working as clinicians in the public health sector. I mean,
Yeah.
I'm trained in psychology, she was a
Mm.
speech therapist,
Mm.
but together the two of us were able to find a way to say the actual issue is what really.
Mm.
And that's where we boiled it down to health literacy, to say that it's people having health literacy, but before you
Mm.
have health literacy, you have to receive health information that is in a format and a manner and a way that you understand.
Mm.
And that is how then we coined the topic. And I was deliberately only focused on people with low literacy, because I suppose the assumption is that people who have got who are literate or educated, they are at liberty to find their own information,
Mm.
in other various ways. I was thinking about people who are dependent on the public health system, who are dependent on the pamphlets, whose only source of health information sometimes is the
Mm.
public health nurse,
I
and
see.
she's using the health aids and what she has at her
Mm.
disposal. Are
Mm.
those materials talking to the people? The language, the English versus
Mm.
Zulu or Xhosa or Sepedi, the
Mm.
terminology used, and
Mm.
and and you know what I mean. So that was where it was. So then we then ended up doing a very wonderful thing. We actually evaluated the National Department of Health's
Mm.
tool. There was a tool, a tabletop tool that they had just
Yeah.
developed for the in fact, for chronic diseases, for
Yeah.
all the chronic diseases,
Mm.
HIV, AIDS, TB, diabetes, and hypertension, and
Mm.
even about nutrition. But
Mm.
we focused on the HIV AIDS section
Mm.
and how they deliver. It also had visual aids. So then I ended up just evaluating these pictures.
Mm.
Who took these pictures? Where do they come from? Are they
Mm.
symbolic to people? Do they convey the messages? If
Mm.
I say this message is CD4 count, does it look like that to people? Where does this picture come from? And there's a lot of that stuff that was
Mm.
very interesting about cultural appropriateness of health education materials,
I
because
like that.
materials that work in South Africa are not the same materials that are going to work in China. We're not
Mm.
living in the same country. And so there was a whole lot of that came up. So it ended up being a very interesting topic. Obviously,
Mm.
apart from just it being a PhD that is completed myself, I learned a lot
Mm.
about something that I thought I knew a lot about when I
Mm.
started.
You know,
Yeah.
just from when you are responding to that very initial, it didn't even form part of our initial question. There's another generic question that I'm going to ask you. And this is a question I put to almost all the academics. And I said, to what extent does pursuing a PhD shape not just what you know, but who you become, particularly in relation to activism, politics, and public life? Maybe you have a thought on this.
It shapes it a lot. I think it does that more than it gives you a qualification.
Right.
So you get the qualification, and that's what people see. Right now, you were worried about whether you're going to offend me if you don't say doctor or prof. That is the least bit of my worries. What the PhD does, and what I've heard from a lot of other people that have
Yeah.
also traveled the journey, it does very much shape you as a person, your character.
Yeah.
It
Yeah.
shapes also your activism, because being involved in the subject matter for that long. I mean, my
Mm.
PhD, for example, if I give you, it was supposed to take 3 years, because it was at a time when the universities, and I completed it at the University of Pretoria.
Mm.
So you can imagine that, first of all, and then took 5.5 years
Mm.
because of the glitches and delays and, the things of
It
PhD.
seasons you out
And
nicely.
so that is a good chunk of my life where I
Yeah.
spent just thinking about this topic, and it wasn't fun. I mean, I think that a lot of PhD people tell you that
Yeah.
it's not fun to do a PhD because there's just so much more in-depth questioning that you must do. And a lot
Mm,
of the time, people that I spoke to throughout the PhD life,
yeah.
most of them would say, you know what, Njabulo, just give this thing up. Because they would see how much it was eating me up. But it
Mm,
eats you up as a person because you are constantly questioning and, and so it's not just you taking literature and doing literature review and then
mm,
saying something.
mm.
You are not just saying something, you
I
are
like it.
yourself, you dig deeper than you would ever think. So
You
it's
see,
beyond. So it really was for me one of the most frustrating things
mm.
I've ever done, to the point that I don't know if I would do another one. I
And
know
it's
there's
expensive. I see a
it
quote somewhere, someone saying that a PhD is a long, expensive journey into doubt.
yeah, it takes a lot out of you. So definitely you will not come out the same person. You
Mm.
definitely are going to be an activist of sorts,
Dr.
yeah.
Banda, yeah, Dr. Banda, you emphasize promoting a culture of research scholarship. What structural barriers currently limit research productivity and research translation in African health institutions?
In African health institutions.
Yeah.
And when you say structural,
When I say,
what
so
do
the
you mean?
question is, you emphasize promoting a culture of research scholarship. What structural
Yeah.
barriers are currently limiting research productivity and research translation in African public health institutions?
Well, public health in African institutions and
Mm,
African sort of systems as well
mm,
is very much infiltrated and influenced by the outside world because
okay.
of funding, because of global health agenda, because of us also trying to be aligned. So it's good to be aligned, very, very good. It's also good to have people that are so focused on helping other countries.
Mm,
It's great to have funders. And I think there's obviously a shift right now with a lot of the funding
yeah.
pulling out of African countries. But the main thing that I've seen is that you will always be a little bit limited in terms of what you want to say and study if you are if you have a funder. And I know funders are very big on saying that they
Influencing.
don't yeah, they're not influencing and they're not instructional in their ways, but some way somehow you are limited. I'll give you an example. When I used to
Mm,
work for the NGO sector, we were funded by the big funders in
mm,
HIV and AIDS. There
mm.
was a lot of things that you couldn't say because of a clause in
Source of
something that
funding.
you've signed.
Yeah.
And because there's even a clause that you would sign, for example,
Yes.
this one funder, whose name I will not mention,
Of
for
course.
example, they did not believe in termination of pregnancy. But the National Department of Health has got a big chunk of work in terms of giving young people that as part of the sexual and reproductive health and rights package.
Mm,
But you cannot work freely in that. And it's not about whether you as a person believe in it or not.
or not.
There's
Correct.
just something that this particular funder has against that. And so you are limited. Even if you think this is the most incredible topic, you want to, for example, I've got a friend who's an activist. She does work in that area.
Yeah.
And I was always very envious of her because she was more talking about how the illegal types
Mm,
of termination of pregnancy, the
mm.
people that post in the streets. So
Yes.
her activism work is about removing those posters and just
Oh, I
making
can
sure that
imagine.
we not have young people dying because of that. So giving the
Mm.
right information, even for
Having the right
prevention of
access.
pregnancy.
Mm,
Yeah, but having the right access to the Department of Health's facilities and
mm,
places. And so giving information, people. So what draws young people to these secret places and having these back streets?
mm.
And so
Yeah.
that's great work. But if you are working in one of these NGOs and you are working for a funded project, you cannot engage in that kind
I
of work. And
see.
for example, I'm an African woman born in South Africa, love the young people. So it touches me to see that
Mm,
as an issue. But because of where I work, then I cannot be researching on that.
mm.
And so,
Interesting. So, which means
yeah.
that is funding? I mean, even when even in academia, like when a degree is funded, when let's say masters or a PhD, is that some kind of a way of disciplining thinking or policing research?
I must say, when it comes to within academia, there's a
Mm,
lot now and this is the difference. Like I also want to allude to in terms of my own journey as well.
mm,
So working for an organization that is funded or being in the field of academia is a little bit different because
mm,
research is a bit broad. and researchers are looking for novel ways. They are looking for things that haven't been done before. So I must say
Yes,
there's a bit more freedom in academia
I
to
see.
study what you want to do what you want to do. And you'll find very little pushback in terms of doing it. Where it becomes tricky,
Is
you asked
in
me about this, the health parts and what are some of the challenges in terms of doing the research, is that um, health in itself is still viewed predominantly medical. And so,
oh,
in
I
terms of now
see.
seeking journals and where you are publishing, there's a lot of, I think, I always say to my friends, it's very political in terms of who will choose your work and who will publish and why they will publish. So there's a lot of public health work being done, and so, but I've noticed that there's a little bit of an incline towards the medical field.
I
I
see.
mean, we once attended a research symposium where one of the guys, I think from the NRF, was analyzing the highly cited researchers across the world. So they had sort of like disaggregated the data in terms of who are they, in terms of name, from which universities are they from, are they in partnerships, and what subjects are they publishing. And the top people were like health and sort of like environmental, type of thing. But the health people were medical people. So
I
there's that
see.
inclination. I find that health is really predominantly clinical. And so even if you're doing public health, you'll find that people are more interested in TB cure rates and all these things. And for example, myself, I'm a human scientist, and a lot of social science people are now doing public health work. So, but you have to coin it in a way that still appeals to practitioners.
I
But
see.
sometimes you're not talking about a practitioner issue. You're talking about a social and structural determinants issue,
Yes, which is
a
my
health
next question.
security issue. You're not talking, so it becomes a bit tricky in that way. Yeah.
This is that leads me to my second question, which is how do social and structural determinants of health manifest differently in African context compared to dominant global public health frameworks?
I think social and structural determinants are everywhere, and their effect, so to speak, is the
Yeah.
same everywhere. But you're right. The way that they are managed in a first world country somewhere else is not the same as in African countries. You see, the thing about African countries is that some people, their very method of seeking health is governed by social and structural determinants.
Yeah.
So, for example, if they are poor and they are young or they are black or in a rural area or far from the clinic, surely their options are now only the public health sector. So the social and structural determinants have done their thing already. So it has a lot to do with that, a lot of a lot to do with the fact that the context is different. And remember, countries like the US, and I think the US predominantly, and maybe some other European countries, their health systems are not the same as us. They've got
Yeah.
more universal health coverage. And so even if there are social and structural determinants, but the available health services for people are not the same. Whereas in Southern Africa, for example, which is where most of my work is centered around, like Lesotho or Botswana or South Africa, people are more dependent on the public health system. So they are still dealing with the same social and structural determinants, but the services that will talk to that and address those health needs
Yeah.
are not the same, and are not the same. So that becomes the crux of the matter in terms of, first of all, what are the determinants? What are the things that, for example, HIV and AIDS? HIV and AIDS is everywhere. Even
Yes.
Americans have it. As China, everywhere. I mean, I
Yeah.
suppose to a different degree. A lot of African countries, I know we are the ones who are featuring, in the higher end of the numbers, in the global numbers. But young people in Southern Africa or in Africa, they are dealing with so much more than
Yes.
just being infected by the virus. There are studies, for example, that talk about the link between HIV and mental health. And there's a huge
Which is my
link
next
in
question.
adherence.
Yeah.
Yes, the link between HIV and mental health in young people is huge, because some young people, the adherence to medication is not just about, do they have enough healthy food to take before the ARVs. They are dealing with GBV. They are living in homes where there's no parent. They're living in communities that are not secure. And so they also have depression. And so depression is not a good measurement for you to be an adherent HIV positive young person. You see, so the social and structural determinants.
There's various determinants, even commercial, even financial, even
Yes,
economics. There's so much going on there in terms of how
yes,
systems actually, or adherence is a mediated or something. Let me put this
True.
question, which was the thing, which was the where you were at the moment. Mental and youth health are increasingly urgent priorities. In your view, are African health systems structurally prepared to respond to the growing burden?
Not really. I think they are trying, and I think they are scholars, and I agree with them to a certain extent that believe that most African health systems are set up in a colonial sort of way.
No,
They're
I've
more
heard that on the
like
podcast
they're
quite a bit. Yeah.
yes, they are very discriminatory in terms of who they were planning to serve. And we, unfortunately, and I'm talking about all of us, myself included, as a person who works in the field, I don't think we've done enough work to talk to that. We kind of jumped into the system or jumped into governance, with now more black presidents. And so that's the first thing. So the answer is no, they are not. And there's a lot of reasons for it. I don't think we can cover them all in the podcast. Like I'm
Let's
saying, the
have a
first one is
few.
the structure. Of course, let's have a few. The first one is, like I've spoken, the structure of just how the health systems are sort of like framed or designed, but also the design of the programs. Health doesn't yet see mental health as a big issue. That is also more of an African thing. I think in other countries, maybe because psychology and psychiatry and all these things are big. But I've read a couple of policies of mental health in from African countries, mostly South Africa. Health, mental health is still and it goes back to my earlier point of saying that a lot of health issues are still framed in a medical way. So mental health is still, they'll start talking about how mental health is grown because we all know that there's a rise in mental health issues. We've seen a rise in suicide and
Yes.
suicidal thoughts, especially in young people. Then in the policy, it will then the objectives of the policy or the framework or the strategic plan will then move into what the activities will be. But the activities will now not talk to the social and structural determinants or the background or the context. For example, if you're talking mental health in Southern Africa, you should be talking about how many young women are exposed to GBV. But now in the mental health plan, there's a lot of stuff on substance abuse because substance abuse is one of it, is one of the
Yes.
areas. There's also higher rates of depression, but there's just a misalignment in the programs themselves. And a lot of the public health, mental health part is psychiatry. And
I
mental
see.
health is not psychiatry. So when you go to the clinics and there's mental health days on Wednesdays and stuff like that, it's all the people that are on chronic medication for psychiatric illnesses, but that's not mental health. Remember, mental health also is not mental ill health. It's not mental damage. It's
Yes.
mental health. So where is the health part? And a
I
lot
get
of
you.
the issue with mental health is that it is not seen as, Njabulo, are you okay? Or if the nurse sees a woman that comes in, she's got burns and bruises every other week, already that's a mental health issue. You should be already more preventative about it. So there's a lot of it being, first of all, clinical, but also it's more curative than preventative.
I see.
And mental health is really one of the areas that should be more curative because you don't see mental health issues. They're not like a cough or a sore or a pneumonia in the lungs.
Yeah.
So the issue is that so the systems are not prepared to deal with issues that are not glaring them in the face, like COVID-19 or HIV.
Yes, someone come
So
onto the podcast, Dr. Poitier. He says that Africans are very familiar with working like firefighters, only coming out,
yes.
only coming out
Yeah, so if the issue is
when
not
it's upon
glaring,
us, when it's upon
yes.
us, when it's a health emergency, but they're not working to put systems that they don't have to be firefighters. I just wanted to go back a little bit to the point you made about because I've had an academic here, Dr. Maluleke, who says that when the nation started, when independence was achieved by various countries at various times, the nation state started from where it was. It didn't go back to reconstitute itself. And you've
Yeah.
just made this almost a similar remark in that the health system is inherited and it was designed colonial, and that is it had in mind whom it wanted to cater for. Can you just stay on that a little bit and expand it for us?
Yeah, no, definitely it is like that. It is even the way that it is, because if you look at even the resources, the
Yeah.
driving of resources, public health personnel or health personnel rather, where are they situated? if really, like you're saying, if we were going back looking at the health systems, we would compare private health and public health. And we would obviously know, because we know that 70% of the population in Southern Africa or in Africa is dependent on public health. So if you are planning to feed 70% of the population, then you are supposed to have resources that speak to that. But that's not what has happened. So, and if that was happening, it would force us to go back, as you say, to say, do we have enough chairs? Are there enough specialists? Do we have enough medicines or things like that? So it's just a lack of planning for ourselves. So, like you're right, if you inherit something, if had we inherited the systems and then said we're not just inheriting the system in terms of the fact that we are now the ones in charge, but let us unpack each and every part and look at how it speaks to us. And I think, like I said, sometimes maybe it is deliberate because, like I said, programs, and you know how they say about African countries, how we've got all these nice policies that are well written. Our policies are amazing. I love reading them. You know, when I read a policy, I always feel very good, especially the first few pages, because like you'll have the foreword from the minister. Like, you know, they get it. You know,
Feel
they get it.
good. Mm.
Because it is exactly what you're thinking. They are talking about the context, they're talking about the history, how far the programs have come. And then I think, I don't know where the disjointed part comes, where from that vision
Is it
and
not the
from that background,
frameworks? Is it not the frameworks in that everything is conjured up within a particular paradigm, the colonial project paradigm or the post-colonial project paradigm, in that it doesn't fit snugly because the paradigm and the framework that it is trying to fit and the lived realities are somewhat not as imagined. Is that not something you've seen in your research?
it's true. And I think you've actually answered yourself. That is exactly what I was trying to say, is that there's definitely a point where you get to see that the paradigm does not fit the vision, the paradigm under which they find themselves. And it is limiting in terms of what can and cannot be done, whether it is funding or whether it is other. And you know, other policies are tied to, for example, there's the National Health Act, for example. It's a great act. If you read the National Health Act, and if it's the one that gives birth to all the other sort of programs, if
Policies
it gives
exist.
birth
Yeah.
to mental health, it is really supposed to be all aligned. But somewhere between vision and what we want for ourselves and where we are going, how we get there is different. And it could have something to do with government, who the people are in governance, and who the leaders are. Maybe some of the people, they're not competent in the areas. You know, there's deployment in most of these. And so maybe they are not able to articulate the marching orders. They can see what needs to
I
be
see
done,
what you mean.
but
Yeah.
they are not able to because of lack of, or maybe even corruption. I mean, if the aim is to steal some of the money, you know, we need 200 hospital beds in these hospitals, or per place, you know, this is how much we need to invest in the availability of beds, whether or not there are people, so that the hospital has a capacity to handle the people. But if the aim is to be corrupt, then the policy will remain. It is written, right? And it is printed, it is
I see.
published. But the action will not talk to. So it is, yes, and it's not so much a lack of inability to go back. I don't think that the health ministries are totally unaware or oblivious to the fact that the systems don't speak to their people. I think there is a lack of intentional willingness to change it and to make it better for people, to make it better for poor people, to make it better for their own people.
Yeah. Let's
Yeah.
go back to your research, Dr. Banda.
Something
So
that
the
we,
question here is: health information systems are often described as a backbone of effective governance. So which is I believe
yes.
your area of work and research.
Yeah.
What reforms are needed to ensure data quality and evidence-informed decision making?
Okay, well, yeah, well, you're right about the first line. That is just, I think that's just, it's self-explanatory. So they definitely are the backbone. But I think our systems are really backwards, our health systems, because they are really dependent on paper-based.
Are we living in
The
the
pa-
30s or something? Are we back before Second World War?
I don't know, maybe we are in the one, you know, there's 4IR. I think we are on 2IR, if ever there was such a
Oh
thing,
my
because
goodness.
really the rate at which our
There's even 5-1.
systems
I don't
are,
know.
You see, no, I think our countries are really behind in terms of that. And again, it could be a lot of things. There's just not enough investment that is going into the health systems. And I mean, not enough investment domestically. So, I mean,
Okay.
whether it's within each country or within the health systems. And it goes back to how much they also allocate to the health budgets. So the health budgets are not the biggest budgets that there ever was. Maybe it's because they are dependent on funders, or maybe it's an indication of how low of a priority health is. I'm not saying it's not a priority, but there are no, we know countries, they prioritize, for example, and when we talk about African countries as well, I've raised this point in various meetings
Yeah.
with some of our colleagues from the African Union.
Yeah.
Some countries, they've got other problems. They've got peace issues, security, they've got
Security
no water,
issues. Yeah.
and so those take a lot of the budget and the focus. So
Mm.
it's not that they don't want healthy people, but that is why then they haven't. So obviously, us as health advocates, we are like, please put more health resources, allocate more to the health budget, take it seriously, because if you're not allocating resources or planning to it, you are planning to fail. So that trickles down to the health systems, I mean to the health information systems. So like,
Yeah.
and it goes back to your question about infrastructure and
Mm.
and African health systems readiness for things like pandemics and things like that.
Yeah.
So the infrastructure is just not well taken care of generally. So if there's no, for example, frequently don't have the necessary equipment.
Mm.
So computers and fancy things like that are at the bottom of the list. And they obviously can go ahead because it's easier to print papers and print forms
Mm.
and buy filing cabinets
Mm.
than it is to invest in a computer that works and have constant internet and stuff. And that is where I think the issue is. So some of the paper-based does work, but I mean, can you imagine having a million um, clients on chronic medication and managing them per week or per month to
Manually.
come and get, and managing that manually? So I think that is the issue. A lot of a lot of the times we've fooled ourselves to think that we are doing something about it, because there is work that they're trying to do into filing systems. It's called deep dives, whatever they call it, to clean the system and stuff. But you can't keep cleaning a paper-based system. And then we've got the outsiders, the funders who come and they fund some of the programs. They bring tablets sometimes, they bring programs. There's some, I mean, a lot of the African countries sometimes, in terms of who funds them, are reporting on international databases for programs
Mm.
that has been brought on by the funders, and those are efficient. And whilst those programs are there, by the way,
Mm.
the health ministries also benefit from that,
Mm.
because they get to see their data. It's sometimes on a live system, or if it's not live, it's web-based, but it works.
Mm.
And so maybe there's a degree to which our systems are too dependent on the fact that sometimes we've got those systems, but those are not ours.
I
So my
see.
issue is that domestically, we are not seeing that we have a problem. We don't have systems that work, and it's not
So
okay
our own
that.
sovereign systems, for lack
Yes,
of a
our
better
own
word.
systems.
Mm.
And I think that's where we should start asking, is it because we can't afford computers? Is it because we don't have load shedding in the I mean, we don't have electricity in the rural areas, or
Mm.
because we've got frequent electricity power cuts, or we need
Mm.
training, and then if it's a money issue, then we should raise it as such and deal with it. But I think ministries are too okay with the fact that a lot of other things are happening. I mean, there's a lot of wins as well in
Mm.
Africa in terms of some of the programs and how we manage testing numbers, management of chronic illnesses, the changing sort of dynamics in what are the leading causes of death,
Mm.
managing things like HIV. So we've got all of those wins, but data is an issue. And this is why also funders are always able to catch us out, because they are very data driven
Mm.
and they demand data
Yes,
like we
because you have
demand
to see
air.
how the money is spent.
Yes, and also because they know that if they have data, then they can tell us what to do, because they've got information.
Mm.
But they
Mm.
bring their
That is a
systems
new
and they've
goal
got
now in all
information.
sectors. Eh?
Yes, they've got the power. Information is power.
Mm.
And we are not using information that we have to make the power to have our own decisions and also just to govern our own programs. So, I mean, yeah, like I said, there is information. I'm not going to
Mm.
lie. The National Department of Health in South Africa, I know they've made strides in
Mm.
some of the programs, in how they manage some, even like I said, it might not be everywhere, but a whole lot of improvement,
Mm.
But there's just so much more that we must do, especially for patient management.
Mm.
It's not efficient for patients to have multiple paper based files and for us to try, even for the people on the ground, it's frustrating. But what is it saying for us on the top? How are we managing a program where we are dependent on so much human error that can happen throughout the levels as the data goes up? Yeah.
So, Dr. Banda, you work across the continent from what I understand, and you collaborate with others across the continent and global south because this is your Africa-India health diplomacy that you are starting out on it. What patterns do you see in terms of how colleagues are dealing with these kinds of similar challenges from elsewhere across the continent or from other countries, perhaps in the global south?
So first of all, I don't necessarily work across the continent, but you're right. I do collaborate with the colleagues a lot, and sometimes even just virtually from just
Yes.
reading and interest. I do also. I'm also a research fellow at the Institution for Pan-African Thoughts and Conversation. That is at UJ. That's where I did my postdoc. So a lot of the work that they're still doing is still it influences what I'm doing now.
Correct.
But to answer your questions in terms of the patterns and the challenges, is that and this is what we're trying to do with that Africa India blueprint. We're trying to document lessons learned.
Okay.
We're trying to sort of have almost, for me, what I was thinking about it yesterday, it reminds me of a South to South collaboration on steroids.
Yes.
The African peer review mechanism
Yes.
and African Union, they've really been promoting South to South because that is,
Yes.
we are birds of almost of a feather as
Yeah.
southern countries or countries of
Yes.
the south. We have
Yes.
similar. We're not the same, obviously. Nigeria is not
Yes.
the same as South Africa or the same as Tanzania or Uganda, but we are similar in terms of the region, in terms of maybe some of the demographics.
Yes.
And so this is why, yeah. So but what has happened is that I think South to South is really still high level. We have not gotten to the point whereby we are doing it. And I think health is one of the places that we need to do a lot of South to South collaboration, learning from each other, because a lot of what happens in any other country is what can be replicated. Maybe
Yes.
not the same way, but you can learn from it. We don't have to have 10,000 different programs happening everywhere. We can have one program that is
Efficient.
cascaded in different ways. That is efficient, yes, but that can work and then someone can tweak it elsewhere.
Across.
And so I think there's limited sharing across the countries of the South, limited documentation, or if there's documentation, that work is not being sort of publicized enough. So we as African countries we're not, like I said, we're not as bad as we think we are. There's a lot of good work happening in health. There's a lot of NGOs that I hear. Some of them are African NGOs, not
Okay.
just from the West. So there's a lot of work that is done in health. I mean, we have been a field for research for a long time. So there's a lot that has happened that we have seen that we are capable of doing, that we have done, because even though it is funded, it is our foot soldiers on the ground that do the work.
Absolutely.
So the issue is the lack of sharing of learned lessons, the lack of collaboration amongst ourselves. There's too much of an outward focus out of the
See.
continent in terms of an inward focus, and that is a general outward focus, not just in health. You know how our continent is. We tend to look more outward
Isn't
than
it the
inward.
colonialists are still interested? They still want to go and anchor their thinking in the north. And I was
Yeah.
but let me take this question on SDG 3. Agenda 2063 and SDG 3 set ambitious targets. From your perspectives, where is Africa making measurable progress, and where are we struggling or lagging, or structurally lagging?
In terms of in terms of SDG 3.
Yes, and Agenda 23, Agenda 2063.
Okay, well, the first part, I think I mentioned it in some of
Yes,
and you
you
might
did.
in some of the work that you have read, is in terms of utilizing the framework.
Yeah.
The framework has got targets and objectives. And for health, for example, I definitely feel that the health the health objectives have not been internalized and thoroughly interrogated by the member states. to see how far they're moving. In fact, they're falling behind. And some of the time as well is because there's just too much going on. Maybe it's there's UN SDG, then there's Agenda 2063, and then we say they're all aligned. I think maybe sometimes people get confused between the things that all sound like they're the same.
And there's
For
national
example,
development plans.
yes, and then there's other things. So maybe we are getting confused, but there's definitely a lack of clarity in path in how we move, and that's why you'll find that. And also remember the measurement as well in terms of monitoring and evaluation. There's not always a direct monitoring and innovation plan that is talking directly to the plan, for example, to Agenda 2063 and the African Health Strategy. So if people had a plan and say, this is the plan, and we are going to religiously
Yeah.
look at how far we are going, I think that is where the issue is, because now we find that we are doing bad in health system strengthening. We are far behind in universal health coverage. And again, universal health coverage in itself is a very big elephant in the room. It needs
Yes,
to be taken
absolutely.
in small bites. But if we were doing some of the things that would feed us moving towards a health that is equitable for all, we wouldn't be so far. So I think there's just an inability to operationalize some of those objectives and to see some of the areas whereby we can be contributing. Because I do think that Agenda 2063, like you said, it's too big,
It's broad.
But if you break it down into small biteable sizes, and that breaking down is not happening, or if it is happening, it is not efficient. And if it's not efficient, then it'll almost be a guarantee for us to fail in trying to establish those goals.
Looking ahead, 2030 and beyond, what strategic investments are essential if Africa is to be a resilient, equitable, and future-ready health system? You have touched on this question, but perhaps there are smaller parts there that I want to tease out nicely, because this is the one that throws it forward to the future.
Definitely harnessing regional support. That South to South collaboration, that India, South Africa, because the whole rationale behind that Africa India blueprint, or that report that we just published, is a learning from similar countries. So
Yes.
definitely an inward look. An inward look, not to say we don't need anyone from outside, but an inward look in terms of what do we have, where are we going, where are our wins, and
Yeah.
what do we have as a region. Definitely an inward look, and an inward look, but also an inward definition of what we define as health security and
Yes.
health sovereignty in terms of us. We need to not feel like we are being pulled by a master, and there's a degree of that is still happening. So health being a priority, but us feeling that we have got our health under control. Not that everyone is healthy or we are at the end, but we have health sovereignty. We have systems that we've put in place. Also, local health financing.
Yes.
There's a lot of financing that is happening, in the African trading regional, the AFTA. So
Yes.
all of that, we can look. There's BRICS as well,
Yes.
for some countries that there's more countries that entered BRICS. So if we harness some of those regional sort of frameworks and platforms and partnerships,
Yes.
because the more you look outside, it's just an issue.
The
I
more
mean, we are
dependency
not.
is propagated,
Yes,
and
and also
yeah.
in terms of currencies, I mean, European and also or Western currencies versus our currencies it's just a lot. So definitely for us to harness, to look at ourselves, what are the resources we have? Where are we going? What can we learn from each other? What can we harness? What can we replicate? And
Yes.
what can we strengthen? But also definitely being very serious about financing, domestic financing. And there's a lot of talk that's going on about it. Like, I mean, I've mentioned some, but we definitely need to be more serious and more deliberate about that one.
Dr. Banda, you're still going to give me final thoughts. And in your final thoughts, please mention a person, 2 or 3 people that have inspired your work, because we always work in an ecosystem. So, final thoughts.
Oh my, final thoughts. That is a spanner in the works. A spanner in the works.
What didn't we
Uh,
cover? Okay, let me, final thoughts. What is keeping you awake now? What kind of health systems research are you currently cracking your brain on now?
No, what keeps me awake currently definitely is issues of youth health. I'm very passionate about youth health, but also women's health. And and like I said to you earlier on, just trying to frame it in a way that is understandable
Yeah,
enough for it to get out there for the
correct.
researchers, because language that you use for the researchers is
Yes,
not
to
the same as the
communicate.
one they use for the communities. But definitely, and also because I'm an academic now, but that work that I've done in the NGO sector,
Yeah,
it still resonates very much with me.
absolutely.
So I'm very passionate about how we make research edible for people, and so that's what keeps me awake at night. Now I'm thinking, oh, well, if one, because I think, like you've mentioned, one has been able to, if I can call it an achievement, achieve that milestone of being able to speak on various platforms, global or regional, that's
Yeah.
fine for me as a person. But what you want is for your work to be meaningful to to communities, to society. And I never want to be at a place whereby we are just talking research and traveling and doing high policies elsewhere, and the work is not meaningful. So I'm constantly trying to look at doing research that has a potential to impact, not just a potential to make me to be highly cited or known or famous, but is it impactful? And so, and like I said, that's not always what the world is looking for. That is a big challenge. It keeps me at night to think, so now do I abandon what I really am passionate about to do
You know,
what
I
is
can't stop
acceptable?
smiling, and I'm going to interrupt you, Dr. Banda, because there is a promo playing now for Dr. Patrick Ngasa Poitier. He talks the second part of his episode. He talks about
Yeah.
how researchers need to go back to communities and make sure that their research is impacting. When I
Yes.
spoke to another academic yesterday, this episode is going to play in May, he says to me, what if community work, that if they are going to promote you in academia, they should take the impact of your research into consideration before you could get any further promotion. And you are saying the same thing.
Yeah, no, that's what keeps me up at night. In fact, that's what keeps me doing research,
Incredible.
is the hope that it will be like that one day.
Dr. Njabulo Banda, thank you so much for being on the Solomon Atah podcast.
Thank you so much for having me. It's been quite a challenging discussion, but I really am so grateful for the opportunity. You are right. We don't get enough time to speak about our research in a way that is as relaxed as this platform. So God bless. Thank you so much.